And so, but it's an interesting topic, and there's lots of stuff to discuss. And then I will say I really felt that as I was putting together this presentation, is I was hoping like I'm going to come up with a clear framework, provide some clear structure, and the data is just very, very messy, but there's definitely some kind of concrete principles I think that we can pull from the data. So hopefully some of you will find this helpful, at least in some capacity. Today, this is kind of the general structure that I wanted to present. Is I'll just do a brief background on what we know some of the baseline bleed risk to be in a few of our populations that we treat. We'll go through some of the definitions of bleeding that are used in the literature, and then we'll just talk quickly about prediction tools and risk factors that we know of. I'll give 3 quick case examples of kind of theoretical cases just to frame the rest of the literature discussion. And then I wanted to talk about intracranial bleeding, GI bleeding, and cancer-associated bleeding, which I think are 3 areas that affect us probably the most in either impactful ways or just with frequency. And then we'll talk about just some basic principles when looking at resuming anticoagulation, a few different kind of theoretical mechanisms, or I'll say like approaches for resuming anticoagulation, and then we'll kind of revisit the cases, not necessarily with clear answers with what to do, but hopefully for discussion. So this is the primary question that we, or at least I sought out to answer when I started this presentation, which was, we know that major bleeding and clinically relevant bleeding occurs in our patients. It is the main side effect of the anticoagulants we prescribed. And then these patients who then experience a major bleed event, I have found some of the most challenging to deal with this year. When do you restart? What do you restart? Do you restart at all? As you'll see from the presentation, a lot of the literature we have to guide some of these decisions around anticoagulation, or what's been studied, has been in the context of atrial fibrillation. So then how do we apply that to venous thromboembolism when the inherent risks are a little bit different? And I think that this is one of the problems we have. This is obviously a very text-heavy slide, but I just wanted to kind of put out there that there are actually many different definitions of bleeding. Obviously, ISTH major bleeding is the one that we see most often in the studies that we are used to. And so you have to have either symptomatic bleeding in an anatomical site, as listed there, a hemoglobin drop of more than 20 points, transfusion of more than 2 units, have fatal bleeding. And that is a definition used in many thrombosis trials. And then ISTH minor bleeding is bleeding that does not involve a critical site with no significant hemoglobin drop, basically not meeting major bleeding criteria. And then we have that pooled kind of clinically relevant non-major bleeding that's becoming more popular as well. And then you'll see other trials, like I recently presented on Hypatho, and they had looked at both gusto bleeding outcomes as well as ISTH major, because there's different sensitivities and specificities with these different tools, and depending on what you're hoping to show with your trial, you may see different ones used. And so what is kind of the baseline bleed risk, to quote our patients up front when we're starting anticoagulation? So obviously we have the recent COBRA trial looking at bleeding in the acute VTE treatment phase, so the first 3 months, and we saw clinically relevant bleeding of 3.3% on apixaban versus 7.1% on rivaroxaban. Thankfully, the rates of major bleeding were quite low in the trial, 0.2% on apixaban, 0.4% on rivaroxaban. And then what happens in the extended phase, I think we can rely more on Renove for the non-cancer population and then ApiCat for the cancer population. And so Renove having 9.9% rates of clinically relevant bleeding, so combined major, minor bleeding on the reduced doses. Major bleeding events on the reduced doses around 2.1% over in that population. And that was looking at over 5 years, but keep in mind, Renove is not a dedicated cancer trial that we have to rely on ApiCat for. And so the reduced doses of DOACs at 12 months still had major bleed rates of 2.9% and 4.3% on full dose anticoagulants in ABICAT. So I think that's just something to keep in mind, which is the cancer patients, as you'll see throughout this talk, are significantly higher risk for bleeding, but also significantly higher risk for thrombosis. Certainly no surprise to us, but one of the challenging things when we come to then decide to stop anticoagulation. And then throughout the literature, we see that bleeding risk tends to be most common early on in a dose-dependent fashion and higher in cancer patients and those with other risk factors. There have been many, many different bleeding risk prediction tools, and for good reason. I think a lot of people have struggled with the same issue, right? But none of these have really, I have to say, I've never really seen these used a lot clinically in practice. And, you know, even when it comes to like the GIM stuff and atrial fibrillation, I think, you know, the more and more training that I get, the more people say, you know, you really shouldn't be using the HAS-BLED score anymore for anything other than identifying modifiable risk factors for bleeding. It should probably not contraindicate anticoagulation for anybody. And so that is how I am approaching some of these risk prediction tools, because in the studies, they have shown fairly modest discrimination. And then after a major bleed event, these are not necessarily validated tools to then predict, you know, recurrent bleed events. But it does definitely help us, like the BT bleed tool, it just helps us think through, you know, does this patient have active cancer, uncontrolled hypertension, baseline anemia? Is there a history of bleeding? Are they older age? And do they have renal dysfunction, which essentially hits on many of the baseline risk factors that we know exist for bleeding. Because many patients with major bleeding will be at least considered for reversal agents, I just wanted to talk quickly about some of the thrombotic risk that has been documented with some of these. So we don't have readily access to andexanet alpha in British Columbia, and it's still quite expensive. I think partially because Anexa won the RCT trial for the reversal agent did not end up showing any significant difference in mortality outcomes. It did show better hemostatic efficacy, but then it's very interesting to look at the thrombotic event rate. This was only over 30 days, had a thrombotic event rate of 10.3% compared to standard of care thrombotic event rate of 5.6%, and the standard of care arm did include the use of PCC. And a lot of that was driven by ischemic stroke. So keep in mind, like a lot of these patients on DOACs were presumably on them for atrial fibrillation, not necessarily VTE. And when we talk about thrombotic events, unfortunately, these are like combined arterial venous events. And then when we look more at, like, we use a lot of 4-factor PCC still for DOAC reversal in an off-label fashion in Canada. And it has shown in some observational literature to be maybe marginally associated with an increased thrombotic risk. However, more of the data around PCC is observational, and there's many confounding factors to looking at thrombotic risk in patients who have have received a reversal or are being considered for reversal. And so these will be things to think about, especially if andexanet alpha becomes more generic and readily available and we are inclined to use it. I think all of these warrant some discussion with the patient before use, if able, to discuss some of these trade-offs and to be reserved for only the highest risk bleeds. And so just a few, so that's kind of the intro. I'm just going to go through a few case examples, frame our discussion, and give us something to kind of think through as we go through these cases. So case one, I think probably The easiest one of the three, a 67-year-old gentleman with preserved renal function who had an unprovoked DVT 3 years ago. He's now on apixaban 2.5 twice a day, and he presents with hematochezia. He needs 2 units of blood, and colonoscopy shows bleeding sigmoid diverticulum. Thankfully, they treated it with clips, which we can't always do in the sigmoid, and they were able to stop the bleeding. His anticoagulation was held initially on mission. When would you restart? Would you restart him, and at what dose? Case 2 is a case of a lobar intracranial hemorrhage on rivaroxaban. Sorry, she's on apixaban. I changed my mind. I made it harder. And so she had presented with acute right hemiparesis and ended up having a left parietal lobar ICH. Her repeat imaging was stable. And now she's pending rehab. She's day 5 after her bleed. And again, would you or would you not restart her anticoagulation? What would you put her on? Keeping in mind, she did just have a segmental P 6 weeks ago. And then the third case is a GI bleed, a gentleman with a metastatic gastric adenocarcinoma on palliative chemotherapies. He had bilateral segmental cancer-associated PE now 3 months ago, so he's just at the end of his initial 3 months of treatment, although cancer should be 6 months. He presented with hematemesis, and he has friable bleeding tumor in the gastric body, which they clipped, but they acknowledged is still high risk for rebleeding. His hemoglobin was down to 81 on admission, needing 3 units of transfusion, and his anticoagulation is also and so when you look at resuming his anticoagulation, would it be with DOAC? Would it be with low molecular weight heparin? Would you stop altogether? So we'll circle back to these. Intracranial hemorrhage. So this is what I would consider to be kind of the highest stakes bleeding of probably any other anatomical site. And I can see now why, having gone through this, why we will often involve neurosurgery. I think it's not only because it's a critical site, but also because it's incredibly confusing as you dig through the literature about who and what is high risk for bleeding and on what time frame. So having gone through all of the a bunch of the data on this, I now kind of am thinking about these in at least 4 different quadrants. I'm thinking about them subdurals separately from intracranial, and I would consider intraparenchymal and subarachnoid to be intracranial, basically anything that's not subdural. And then within subdurals, I'm thinking about traumatic and then spontaneous, and I would consider any chronic subdural to be lumped into the spontaneous category. And then for the parenchymal bleeds, I now think about them as deep parenchymal bleeds, i.e. more likely from things like hypertension, very different than spontaneous lobar bleed, where we start to worry more about things like cerebral amyloid. And even if it does not confer a formal diagnosis of cerebral amyloid, still seems spontaneous lobar hemorrhages are significantly higher risk for rebleeding. And so this is borne out in some of just the natural history of intracranial hemorrhage generally. Even before we talk about trying to restart anticoagulation, it seems that lobar intracranial hemorrhage has recurrence rates of somewhere around 7 to 10% per year. These are for spontaneous lobar intracranial hemorrhage. And the more I read into it, the more I read that these are associated with often some hemosiderin deposition, concern for cerebral amyloid angiopathy, and tend to have fairly high recurrence risk. This is in stark contrast to a deep non-lobar intracranial bleeds, where the natural history is much different. Recurrence risks much lower, around 1 to 3% per year. And I think this is important talking about upfront, because before we talk about the trials, some of this gets a little bit lost in individual trials. They're not really powered to detect differences by necessarily hemorrhagic location. But all of this, the lobar versus deep, is kind of well established in larger meta-analyses and also in many of the guidelines as it pertains to restarting anticoagulation that we'll talk about. And so I had been at a conference, which was THSNA earlier this year, and there was a neuro ICU pharmacist who gave a really, really good talk on intracranial hemorrhage and whether or not to ever restart anticoagulation after them. And I didn't really realize until that talk that it's actually seems like it's only been in the last, 4 or 5, maybe 6 years now that it's really become consensus that yes, we should give some serious consideration to restarting anticoagulation after an intracranial hemorrhage. And the SOSTAR trial was one of these trials that kind of helped guide that direction. This was a smaller randomized trial out of the UK. And they took patients with spontaneous intracranial hemorrhage. And this, unfortunately, was also primarily an atrial fibrillation population. And they were randomized to either start or avoid oral anticoagulation after a major bleed, or after an intracranial bleed, I should say. And the oral anticoagulation was at the clinician's choice, but it was mostly DOACs. The median time from their bleed to randomization to me seemed quite late. It's like 115 days. And then they followed them for on average 1.2 years, looking at recurrent symptomatic spontaneous intracranial hemorrhage. And overall, it was a very reassuring finding. Actually, none of the 101 patients on anticoagulation had any significant recurrent bleeds. And the rates of thrombotic events were similar between the two groups, but keeping in mind it was primarily powered to look for recurrent bleed events. And so that was one of the trials that helped to say, perhaps we don't have to completely avoid anticoagulation in all of these bleeds. Apache AF came on a little while there later, and that was a small phase 2 randomized control trial comparing apixaban to no anticoagulation. Again, unfortunately, atrial fibrillation population following intracranial hemorrhage. They enrolled just over 100 patients, and there was a shorter now time from bleed to randomization, being 46 days, and they were looking at the outcomes of non-fatal stroke or death from vascular causes, and they showed a primary outcome in 13 patients on apixaban versus 12 patients on no anticoagulation. So effectively, no difference in the recurrence of intracranial hemorrhage and non-fatal stroke. So certainly those were two major trials that were being cited at some of these conferences that kind of led some of the groundwork to say, let's start, maybe a little bit more aggressive, because there have been other major meta-analyses now too showing that restarting anticoagulation is also associated with lower mortality rates. And a lot of that data does come from the atrial fibrillation population as well. So it's difficult to apply this directly to the venous thrombosis population. And then throughout the literature, again, there seems to be consistent imaging features that are associated with higher rates of rebleeding, being lobar locations of the index bleeds, superficial siderosis seen in at least 3 sulci on an MRI, which seems to be a strong predictor of recurrence, and then a high lobar microbleed count, more than at least 5. And then on the subdural collections, anything that has midline shift, a width of more than at least 10, but definitely 20 millimeters is associated with rates of recurrence. And then residual hematoma at the time of restart was also strongly associated with recurrence. I have to say the intracranial stuff became very hairy to try and present in a clean format. I struggled most with this section. And so we're jumping a little bit early, it seems, to the guidelines, but I want to leave time to talk about bleeding in other sites and a few other things at the end. And so what do the guidelines say about restarting anticoagulation after spontaneous intracranial hemorrhage? AHA 2022, they actually explicitly talk about spontaneous intracranial hemorrhage. They say for atrial fibrillation, if a decision is made to restart anticoagulation, consider it later, 7 to 8 weeks. Canadian Stroke. And then they also acknowledge the lobar versus non-lobar location and say, you know, this may need to be considered earlier in patients with a high thromboembolic risk, such as those with mechanical valves. Canadian Stroke best practices essentially say it's uncertain. You need to individualize and consider trying to mitigate as many bleeding risk factors as you can, which is similar for the European guidelines. But recurring themes across the guidelines that they all seem to cite this 4 to 8 week timeline for restarting anticoagulation. DOACs preferred over warfarin, which is nothing new to us. And they all acknowledge that lobar ICH, especially if there's any of those features I spoke about that are concerning for cerebral amyloid. Those are certainly the highest rebleed phenotype. Unfortunately, most of that evidence is in atrial fibrillation. And so kind of coming back to this is kind of my new framework, the way that I will approach thinking about intracranial hemorrhage, because I'm really trying to frame this into, you know, what is their recurrent bleed risk, and then comparing that to what is their risk of recurrent thrombosis. So again, the deep bleeds, much lower rates of recurrence, making sure that we're controlling blood pressure, which is one of the primary modifiable risk factors for recurrence of these deep intracranial bleeds. And then there's really not much that we can do about the lobar cerebral amyloid type bleeds in terms of mitigating risk of recurrence. So this is a situation I hope I don't find myself in, and it's one of my questions to the audience at the end. Acute traumatic subdural, in theory, there's been a reversible cause for the bleeding. There has been an insult, and so with time away from that, it should be safe to restart anticoagulation eventually. There were several meta-analyses and guidelines saying that rates of recurrent bleeds after traumatic subdurals seem to be low, and that the restarting timeline for anticoagulation should probably be more of the 4 to 8 week mark after a traumatic subdural. Unfortunately, chronic subdural, so even after a traumatic, having residual subdural hemorrhage at the time of restart is definitely associated with risk of recurrence. So I would put them into a higher risk category. And I think that certainly those cases would warrant some neurosurgical opinion about their rebleed risk. Okay, I'm going to move on to talking about some GI bleeding. I'll talk about, I kind of picked a couple of the primary trials that are often cited in the guidelines, and then talk about the guidelines here. This was a study published in the American Journal of Medicine in 2015, and this was a prospective cohort study looking at the outcomes after anticoagulant-associated bleeding in patients with GI bleeding. So these were patients on warfarin or DOAC, and anticoagulation was resumed in 61% of patients within 7 days, and the recurrent GI bleed rates seen at 90 days were around 8% in those who resumed anticoagulation versus 6.6% in those who did not resume anticoagulation. And you can see that the rates of thromboembolism were significantly lower in those who resumed anticoagulation. Perhaps not surprisingly, what was a little bit surprising to me was how high the rates were at 90 days of thromboembolism in those who were not resumed. Although arguably this entire population had an indication for anticoagulation on admission. And so earlier, and then some of their sub-analyses did show that resuming earlier within 7 days actually seemed to have a similar safety profile to resuming later. Yeah, Dr. Schmidt.
Hey, just to clarify, this is just non-randomized following what happens for these patients.
Correct. Correct. Yeah. This is like non-randomized. Yeah. So
So
this is just
potentially there's confounding with the people that are expected to do better, that they'll tolerate that.
yes, definitely.
Yeah.
Yeah. Yeah. Yeah. I was a little bit surprised at the like rates of thromboembolism, given like the prospective cohort nature of this, but yes. Um, and so um, this had led us to also a Danish nationwide cohort trial looking, unfortunately, this population was even less venous thromboembolism patients, so looking at just over 4,000 AFib patients who had GI bleeding on anticoagulation. And most of them had anticoagulation resumed within 90 days. And the all-cause mortality associated with restart, as well as the rates of thromboembolism, were significantly lower in those who restarted anticoagulation versus those who did not restart anticoagulation. And they did a comparison about anticoagulation compared to antiplatelet alone versus no antithrombotics. And my key takeaway from this trial was actually that restarting anticoagulation seemed to have more mortality benefit, lower rates of thromboembolism, without necessarily significantly increasing the rates of bleeding, which helps me to know that if I'm ever tempted to just restart an antiplatelet, perhaps I should try and steer away from that if an anticoagulant is the real good option for them. Some of the older literature from 2014, I know it's this is still one of the commonly cited studies for sorting out the timing of reinitiation, was this 2014 study where it seems that restarting less than 7 days comes with a significantly higher hazard ratio of above 3 compared to starting after 7 days. And then when you look at the rates of thromboembolism, it also seems like, you know, after the 1 week mark is kind of the transition point in terms of risk there. And so the takeaway from this was that the sweet spot for restarting anticoagulation is likely somewhere kind of the 7 to 14 day mark. They had also done some sub-analyses looking at upper GI bleeds, and maybe delaying that by another week seemed to have the most favorable safety profile. But certainly earlier restart than later for GI bleeds seemed to be beneficial. And so what do the guidelines say? The gastroenterology guidelines would say resume anticoagulation after hemostasis is achieved, and suggest resuming rather than not resuming, based on a lot of the primarily those studies we talked about. The specific timing, they steered away from recommending. Some of the European guidelines say non-variceal upper GI bleed. Consider earlier restart for lower rebleed risk lesions, so as early as 7 days, and then consider risk stratification for the higher risk lesions. And based on the literature that I looked through, you know, a higher risk lesion, I would personally look at pushing out to closer to 14 days. And then the CHEST guidelines and ISTH guidelines are similar in the sense that they suggest resuming anticoagulation for most major GI bleeds once the source control has been established, and do not stop indefinitely unless there's a strong reason to do so. Okay, I'm going to move on to some cancer-associated bleeding, which was the most sparse in terms of anything with regards to timing, unfortunately, of restart. So cancer-associated bleeding, I think, is harder because of all the reasons we talked about, right? It's higher thrombotic risk, also higher rates of bleeding at baseline. This is also a population where we tend to see these intraluminal bleeds, the intraluminal GI and GUs. And cancer is one of these situations where we can't often always achieve definitive source control. And then you add all of these additional confounding factors like cytopenias. Are there drug interactions with their chemotherapies that are going to limit certain options? Is their renal dysfunction going to be dynamic in their chemotherapies, et cetera, et cetera? And so we know a lot of this. There's some stuff that we can extrapolate from some of the BT literature. So we know that, Hokusai VTE had shown us that we saw higher rates of major bleeding in some upper GI lesions. That was similar in SELECT-D, where we saw actually lower recurrent rates of VTE for rivaroxaban compared to dalteparin, but there were higher rates of clinically relevant non-major bleeding in the GI cancers in the intraluminal unresected group. And then Caravaggio, obviously apixaban versus dalteparin, non-inferior recurrence and similar major bleeding, including the GI subgroup, which had left us obviously with this understanding that some of these trials have shown that intraluminal GI and GU populations do tend to bleed at higher rates on the DOACs when compared to low molecular weight heparins. And so the ISTH guidance is that after a major bleed in cancer-associated VTE, you should consider dose reduction, consider switching to low molecular weight heparin, or consider temporary interruption with an IVC filter only if anticoagulation is truly contraindicated. And I'll pull the group later, but I think the role for IVC filters, at least for me, would be limited to more the true acute VTE within the first 14 days still, but that is not well established in the cancer population. None of that is really evidence-based. And so in the cancer-associated group, what do we do for restart? I still think we have to just look and try and extrapolate from some of the non-cancer patients with regards to the anatomical location, the perceived rebleed risk. Are there additional local tumor-directed therapies that we can use for source control? Consider their goals of care, and then look at trying to reduce the dose. And I'm not sure if you have a cancer patient that is 3 months into their treatment, is it time to go down to a PIX 2.5 BID, or would you switch them to full dose low molecular weight heparin? I think everyone's going to do something a bit different, but this is where you start to get away from clear evidence. Something I wanted to touch on today was the factor 11 inhibitors, which are very much kind of coming down the pipelines. But in all of these talks I attended this year on major bleeding, it always came up perhaps that these will eventually be a good option, because in the trials to date, although many of the factor 11 inhibitors have shown non-inferiority for things like stroke prevention and atrial fibrillation, they've also shown significantly lower rates of bleeding. And so there is the primary prevention trials for cancer, for VTE and cancer, that are ongoing now with the factor 11 inhibitors. And hopefully those will give us another good option to have an even lower bleed risk for primary prevention. But then perhaps one day we will have something for secondary prevention as well that is significantly lower bleed risk in the patient population. So I think still too early to say. This is certainly not something that I would be reaching for anytime soon, but once they're available and with more data, it may be a consideration. So I just want to go back to those clinical cases that we talked about, and we'll go through a little bit of how some of the evidence can be used to anticipate their recurrence risk, and then also incorporating some of what we talked about for their bleed risk. And so case one, this was the gentleman on Pixman 2.5 BID who had non-provoked DVT 3 years ago, who had a major lower GI bleed from a sigmoid diverticulum. His source control had been achieved, and Pixman 2.5 was already his lowest appropriate dose. And so what would his recurrent VTE risk be? Like, really, I think that is one of the major things to consider when we're having to individualize a lot of these. This is probably my most commonly referenced table in all of fellowship, which is this BMJ 2019 paper that pools a lot of the data to give us really more accurate rates of what are the recurrent VTE rates for patients with first unprovoked VTE. And so I didn't separate them male and female, which are the ones that I usually cite here, just to make this more readable. But we know that men with unprovoked VTE have recurrence rates of cumulatively probably around 30 to 40% at the 5-year mark, highest in the first year, and then slowly dropping thereafter. And so with his anticipated risk of recurrence and source control achieved, I would certainly just look at resuming his Pixman 2.5 BID around the 7-day mark, and earlier than that, I would be just doing DVT prophylaxis in hospital. Case 2 was our lobar intracranial hemorrhage lady who had a segmental PE 6 weeks ago on a Pixman, presented with a lobar intracranial hemorrhage, and is now 5 days after her bleed. And there's been no evidence of re-expansion on repeat imaging, and she's waiting for now rehab. And so with her bleed risk, we'd be looking to try and mitigate any factors for rebleeding. She is certainly higher thrombotic risk, or at least you would think that, because she's less than 3 months out. So what does the literature actually tell us? Sam Schulman actually asked this exact question almost, comparison of 6 weeks versus 6 months of oral anticoagulation after a first episode of VTE. And he included both DVT and PE patients, but this was back in 1995, so this was primarily warfarin that was used in these trials. Stopping at 6 weeks resulted in recurrence rates of around 18% at 2 years, compared to if you can extend it out to 6 months, around 9.5% recurrence rates at 2 years. There are certainly newer trials showing very similar tendencies for recurrence risk. I just thought it's fun to go back to someone who had studied this exact time frame. And so her recurrence risk would probably be somewhere around 18% at 2 years if we stopped anticoagulation now. Maybe could it be higher because she's admitted to hospital with this new acute insult? I don't know. This is part of the challenge with restarting anticoagulation after a major bleed. And so I'd be curious to hear what you guys would do for her, but given the unprovoked lobar intracranial hemorrhage, to me, this is associated with significant rates of recurrent bleeds. And I would be, if they were comfortable, looking at doing DVT prophylaxis in hospital and then having to stop. The cancer-associated bleed case that we had was the 59-year-old gentleman with metastatic cancer on palliative chemotherapies who had bilateral segmental PEs 3 months ago. And he's currently on, or was on a PIX5 BID when he came in from with bleeding from the tumor in the gastric body, which was clipped, but there is an ongoing high rebleed risk with the unresected intraluminal GI malignancy. And so unfortunately, he will never have absolute definitive source control. We could consider things like palliative radiation as an option for him, make sure that additional things pop up like low platelet counts and things like that. And so if he wasn't already, I think this was the one that was on rivaroxaban. I changed the case to be that he was on a apixaban. So I'd be curious. So he's already on the kind of best DOAC that exists in terms of GI bleeding in theory. And so what I'd be curious to hear what you guys would be doing with this gentleman who's now 3 months out. Which led me to look into a little bit more too about the risk of recurrent VTE when we stop anticoagulation, perhaps a bit early in these cancer-associated thrombosis populations. And the rates of recurrence to me were actually quite high. In the first 3 months after discontinuation of anticoagulation for cancer-associated thrombosis, the pooled event rates were around 14.6 per 100 patient years. And then it starts to add up so that by the 1 year mark, the recurrence risk was around 28.3% to this meta-analysis, around 31% at 2 years, and then 31.9% at 3 years. And so his recurrence risk in theory is still high. So again, I'd be interested to hear what you guys would do with the intraluminal unresected GI. I would be inclined to transition to low molecular weight heparin. However, what dose? I don't know. And so if I'm trying to kind of summarize a bit of an approach for when I encounter these situations, to me, it's going to be really sitting down with the literature to understand what is their risk and consequence of rebleeding. Certainly, we can and do rely on neurosurgery to help time the restart and appropriateness of restarting anticoagulation. But I also think that it's a bit on us as the thrombosis physicians to understand more about their thrombotic risk so that we can help find that balance, which is really our role in number 2. And then number 3, making sure that they're already on the lowest effective dose on the most appropriate agent based on the site of bleeding and the agents that we know are associated with lowest rates. And then considering the time of restart. So GI bleeds, I would probably do 4 to 14 days after hemostasis, intracranial hemorrhage, no sooner than 4 weeks, probably out to 8 weeks in most cases, unless there's a very urgent indication with high thrombotic risk. And then really trying to optimize everything else that you can in terms of modifiable bleeding risk factors. Are they iron deficient and not on a PPI? Is there NSAID exposure that we can stop? Is there hypertension controlled, etc.? And then as always, I think, especially when there's not clear evidence and some vague guidelines at times to guide us, then shared decision-making with the patient is critical. There was a very recent paper that I didn't include in full. This was published in Blood Advances, but this was essentially just kind of a theoretical model of trying to incorporate numerical bleed risks with numerical risk of recurrent thrombosis and try and assign essentially a number to patient value and preferences, which I found a bit confusing. How like the regret of commission over regret of omission. Essentially with the idea that maybe one day we can actually just put these all into a graph so that we can have a more clear estimation of at what time frame in someone's thrombotic course does their bleed risk really start to outweigh not only their thrombotic risk, but also their personal preferences. This to me is not, something to implement now. This is, I think, just another kind of interesting way to think about these problems. This is a very analytical approach to this, but I'm still not really sure. I hope I left enough time for discussions. Some feedback I gotten previously was that I should try and pose some questions to you guys. If you don't have any for me. And so my thoughts going through this and having been through the years, are there situations where you would consider dabigatran? I've done it once in a patient where neurosurgery was really worried and they really wanted something reversible, but I'm not really sure. Have you ever successfully restarted anticoagulation in one of these low bar cerebral amyloid patients with success? And then do all of these numbers seem to clinically fit kind of what you're seeing